So good morning, everyone. Hopefully you can all see and hear me okay, and if for any reason you can't, please put it in the chat and we'll get somebody to pick it up and take support and let me know. We're going to get started. We've got quite a few speakers today that have kind of given up their time, so I'm keen to make sure that we give them all the time that they can get and give you a chance to explore some of the issues that they're going to be chatting with you about today. Can I ask everybody, unless you're a speaker, to mute your microphone and switch off your camera? It helps with bandwidth and also means that there's no background noise for speakers and stuff to be distracted by. So if for any reason you're having any issues with any of that, we do have tech support, and we'll put in the chat the email address to contact us if you've got any issues. We're going to shortly launch a poll, and part of that is to help us in our co-design of our future webinars. So please engage in it, and we would hope to hear from you about what you think our future webinars should include and some of the detail, but also critically where are you joining us from. Just helps us get an understanding of the kind of breadth and depth of engagement that we've got across people who are interested in relation to drugs and alcohol. So let me just do a bit of kind of housekeeping whilst that poll's running in the background. So thank you very much for you all taking time out, I know, which is a very busy system at the minute, and getting a chance to kind of engage in learning and development is really challenging. So I really appreciate you taking the time to do that. I'm going to take you through some sort of housekeeping. As I previously said, please make sure that you turn off your microphone and your camera unless you're a speaker or unless we invite you to contribute. It just helps with bandwidth, and we've got quite a lot of people signed up for today. So it just makes it a lot smoother for everyone else. We do ask that you use the chat function and engage with us, and you'll see for those of that have just joined, there's a poll live at the moment, and please complete that just so that we can get a good understanding of the breadth of the engagement that we've got and actually some of the subjects you might want us to cover in the future. If you do have any technical difficulties, if you just email us at his.mat, his.mat@nhs.scot, and we've got a team in the office who will be able to pick up any kind of residual issues. Our webinar today is about data sharing and purposely in relation to preventing harm. We've heard quite a lot across the course of the drug and alcohol programmes about the importance of data sharing and how it can be either a real positive thing in relation to improvement of care, but also a hindrance to good care and continuity of care. So today is an opportunity for you to hear from some subject matter experts around that, and also explore with them some of the key issues that you may or may not be experiencing in delivery of your service. Before we get started with the official webinar, I just wanted to give you a bit of a trigger warning. So drugs and alcohol, historically, and we all know this from our experience in delivering services, is a very emotive and challenging subject area. And whilst we try and avoid giving any personal experiences across drugs and alcohol, we can't really avoid a really difficult discussion about the harms that are caused. And sometimes our audience, and particularly for those that are professionals or those with lived experience, might find that quite triggering and upsetting. So if for any reason you feel that the content that's being shared is upsetting you, please look after yourself and leave the webinar and pick a call up with me separately so that we can have a discussion about what we could maybe do better in the future and what we could learn from your experience of engaging in the webinar. Please remember that the chat is a public forum, so anything that you put in the chat is available to the general public. So we would avoid any reference to any particular cases that you may be supporting or discussing any individuals who may be identifiable through that discussion in the chat. However, please use the chat because it's a really good resource for us to understand exactly what the discussions and the content need to be in the long-term development of our webinar series. So please don't see that as being something that you shouldn't engage in. We absolutely want your engagement in that. So as the poll runs, let me just give you a little bit of brief context for today. Over the last few years in relation to drugs and alcohol programmes within Healthcare Improvement Scotland, you'll all know that we're doing work around mental health and substance use by way of protocol development. We have our MAT standards work that we're working with our MIST colleagues in Public Health Scotland around, and we have our residential rehab programmes. And across each of these programmes of work, there's common themes that tend to rear their ugly head on a regular basis. and data sharing seems to be one of them. And we've tried our best to try and understand exactly what's going on and how might we help the system understand the governance around data sharing and also limitations, but therefore what are the contact points in the system. Over the course of the last year, we've spoke to a number of people providing services within drugs and alcohol across Scotland, actually, and consistently they tell us about the issues in relation to data sharing, but also what does it mean to have consent to share data, and what is the challenges when you're dealing with a difficult or complex group of people who have family members connected to their care, and how do we keep everyone safe. So today is an opportunity for us to bring that to life and let you hear from professionals in the system who've got a really interesting perspective to give you, and guidance from the legislation right through to how we're transforming care, or how the system is transforming care to ensure that data shared and data is being used to ensure better care coordination. So today is a kind of opportunity for you to hear from those experts, but also get involved in a discussion and a debate about data sharing and its importance, and what do we need actually to deliver care in the long term for people using drug and alcohol systems and services. Before I get started and show you the agenda, I just wanted to take a quick opportunity to introduce to you one of our newer staff members, Carrie Thompson, whose picture is on the screen, I think. So Carrie has only been with us, I think, for about 3 weeks, and has taken over the role of our Senior Improvement Advisor, and will have accountability and operational responsibility for the delivery of our MAT Standards programme now and into the longer term. So if any of you want to pick up a call with Carrie, I'm sure she would really welcome that. Some of you may know Carrie from her work history, and Carrie's really excited to kind of be part of this work. So she's in the background just observing today, but if there's anything in specifically you want to catch her about, that's her email address there. And if you're not sure about how to engage with us, then please let us know about that and we can sort that out. So welcome, Carrie, and hopefully you enjoy today as much as anything else. Can I just move on to the agenda then and just give everybody a quick sight of this? So our first speaker today is George Fernie, who will introduce himself, and he's going to cover Caldicott principles and the importance of good practice. We've also got a colleague, Alison within Healthcare Improvement Scotland, who's an information governance lead, and she'll be chatting to you about the principles of information sharing. We're hopefully taking a break round about 11-ish. We'll see how time allows. And then afterwards, we've got Melville from Angus Health and Social Care Partnership, and she's going to chat to us about the Dundee near fatal overdose pathway work to bring it to life in terms of data sharing as much as anything else. We would ask that participants use the chat to propose any questions or comments or reflections, and if time allows, we'll propose them back to our speakers today. If for any reason we don't have the time to pick up those questions, what we'll do is we'll get a download of the questions, we'll ask the speakers to contribute, and then we'll circulate that to everybody who participated today. As ever, our webinars are being recorded and they'll be available to share once we've loaded them onto the website. I would encourage you to share that across your peer group or anybody who you think has a particular interest in this area. Okay, so I think you've heard more than enough from me. George, can I just ask you to open your camera and your microphone, please?
Yes, so I should be on camera just now and you should be able to hear me all right.
I can indeed.
I'm about to try and share my, let me just
I think we should be able to manage the slides for you, George, if you just...
I'd rather do my own ones if this works, if it'll let me. Just hoping. Here we are. That you should be seeing that just now, and that should be full. Is it full screen? Let me just. There you go. It should be full screen just now.
That's great. Great. Yeah, I shall come back on screen, George. Just about a minute to go, just to give. So just ignore me, but just to give you a wee. Warning hour. Great. Over to you, George. Thank you.
Thank you. So I'm George Fernie. I, like Ruth, work for Healthcare Improvement Scotland, and my main role, you'll see from the logo at the top there, is to run the Death Certification Review Service, which is in its 10th year. However, equally important, or perhaps more so for the organisation, is the fact that I'm the Caldicott Guardian, and I'm going to talk to you a little bit about what that involves. When you're talking about trigger warnings there, Ruth, interestingly, because I've been a doctor for 47 years, I was thinking that I've always had to have a professional involvement with drugs and alcohol over that time. Initially in my career as a GP, which I thoroughly enjoyed and gave me a good grounding in being able to understand the principles of sharing information, but also dealing with people and the consequences it has for them. But then as a forensic physician, what used to be called a police surgeon, and when I later went on to be the third president, that's the middle logo there, the Faculty of Forensic and Legal Medicine, working with severely disadvantaged people from all sectors of society that were in the police custodial system. It's incredibly vulnerable, but with a need to share information appropriately there. And I won't go into this, but the other thing that I'm doing just now, I'm just come out of a meeting for that, is I'm currently chairing the UK Caldicott Guardian Council for the next 3 years, and I can give you some further background if necessary later on. But what is a Caldicott Guardian? So typically in Scotland, it is named after Dame Fiona Caldicott, who was originally Scottish, born in Troon, although I don't think she ever practiced here. But it's a senior person within a health or social care organisation, making sure that personal information, and this is our mantra, is used legally, ethically and appropriately, and making sure that confidentiality is maintained, but that's not an absolute right that people have, and we'll go on to talk about how that can be shared to the benefit. We have 8 principles now. Need for common sense and an understanding of the law. As it happens, I'm duly qualified in law as well as in medicine. Well, one of those processes wasn't bad enough to go through, so I went through the second one in middle age as well. But the word I would ask you to look at here that I think is critical is that the use of information is compassionate, and a realization that decisions that we make are going to affect real people, many of whom we're actually never going to meet in person. So what are the Caldicott principles? Well, they're set out here. So it's justification of the need to use patient identifiable information or personal identifiable information, and can you justify why it is that you need to do that? Use it only when it's necessary. So for research purposes, typically anonymized or pseudonymized information will be sufficient to do with that. The minimum necessary that you need to share to achieve the desired purpose. So again, typically with clinical records, it's not an all or nothing phenomenon. It's the part of the clinical notes that you need to be able to deal with what the person has asked you to do with, or to actually the situation in hand. The access should be on a need to know basis. Everyone with access has to be aware of their responsibilities. It's not somebody else's problem. Each of us, it's our own responsibility for that. We need to make sure that there's compliance with the law and that organisations have proper training, certainly on the legal aspects of that. I know Alison Winning is going to talk about that shortly, but also about the ethical dimension that's associated with that. And one of my favourite phrases that I use regularly in talks is, even if it's lawful, that doesn't necessarily mean that it's ethical. So you need to factor that in. Principle 7, which is one of the later principles that came in, the first 6 came in together. Next one was 7, and I think this is something that's going to attract attention today, is that the duty to share information for individual care is as important as the duty to protect patient confidentiality. And notwithstanding that principle being there, we've repeatedly had failing of sharing of information in child protection circumstances. And finally, the no surprises clause, as I call it, that there's transparency in the use of data, where we inform patients and service users about how their confidential information is used, and making sure that you've got adequate privacy notices in order to do that. I happen to have picked this because I think it illustrates some of the principles quite well, but this is the General Medical Council, the regulator for doctors, guidance on good practice in handling patient information, and it sets out there a framework that you can use on disclosing personal information when it's done with consent, which typically you would want to be able to do that, although of course there may be implied consent in certain circumstances. What happens when somebody doesn't have full capacity in order to consent to the use of their information? When disclosures are either required or they're permissive, you're allowed to disclose information by law, and that might be statute-based law, or it may be the common law with precedent with that. So that's under a legal process. It's when disclosures are necessary in the public interest. I'll give you a little bit more about that in a second. When disclosures are prohibited by law, and as I say, I'm not going to particularly go through GDPR and the Data Protection Act. I think Alison's covering that within the presentation. So the next, next slide. Let's just, is that not moving on? Sorry, has that slide moved on? It's not moved on yet, I don't think.
No, I'm not. I'm seeing the confidentiality good practice slide.
Yeah, there we are. Sorry, that's it. There we are.
Sorry, just thank you.
Yep, slight technical hitch there. Confidentiality is important, ethical and legally, but it's not absolute, as I've already said. And there are circumstances that you can disclose personal information without it, and it gives ideas here with it. So for their own care, or for local clinical audit, if the patient consents, if the patient has given their explicit consent for other purposes, if there's overall benefit when somebody lacks capacity, when there is a legal requirement, things like knife wounds and gunshot injuries there with that, or there's a statutory process that sets aside the common law duty of confidentiality, or if it can be justified in the public interest. When you're doing that, and you'll see how this mirrors the Caldicott principles as well, use anonymized information if it's at all possible, but you have to be satisfied the patient has ready access to information explaining how that will be used. That's typically what we would refer to as a privacy notice. If they've not objected to that, and there will be circumstances where you need explicit consent. I'm thinking here about forensic examinations in my capacity as a forensic doctor, and there will be other situations when it's not just their own care that's involved with that. Keep disclosures to the minimum necessary and comply with all legal requirements that are there. So there is a balancing act between the benefits to an individual or society and when they outweigh public and the patient's interest in keeping that information confidential. There may also be circumstances when disclosing personal information is justified, and if you have any doubts about that, the advice here is that you consult the Caldicott or data guardian or a legal advisor before you're doing that. There are very specifically issues when you might release information for the prevention, detection, or prosecution of a serious crime. What is a serious crime? It's not a minor misdemeanor, it's a serious indictable offence. And there may be situations when if you're approached by the police, you still wouldn't release information because you haven't hit that threshold there. So again, simply because somebody asks you nicely, if they're a solicitor, a police officer, or an officer of the court, you may still, unless there's a valid court order, not be prepared to release that. So and I hate to use this phrase, but as the lawyers say, it hangs on the facts of an individual case, and you may benefit from seeking advice on that. Not going to go through this clumsy chart that's there, but there is in the GMC guidance that anybody can access. It's quite a useful framework to go through and look at whether or not it's appropriate to release information and covers these circumstances. Again, implied consent and sharing information for direct care is set out there, again, I won't go through the slides, but happy to share them afterwards and let people have some understanding of it. Going to go on to some practical advantages. One of the big game changers that we had was that when the forensic health care, these are detainees in police custody, when it moved over to the NHS in 2012, one of the real game changers was having access to the emergency care summary with that individual's consent, or in an emergency in their best interest, accessing what had been prescribed for them. Now, one of the drawbacks there is it doesn't necessarily cover alcohol and substance dependency services, but nevertheless, if you're prescribing in that scenario, then it's much safer than it was before that. And as I say, that revolutionised what we were able to do. An example here, this was the Glasgow Herald in circa 1997, I think it was, when I was working at the Medical and Dental Defence Union of Scotland. And this was a situation where the daughter of this couple had approached the practice and the police in the Trossachs, and the parents had gone missing. There was some doubt as to the background of that. I spoke with the doctor that phoned up for advice and suggested that a limited disclosure was appropriate. And as it turned out, the two parents were eventually found buried at a farm in West Kilbride, having been shot, and it was a criminal investigation. We obviously didn't know that at the time, but I believe it illustrates an appropriate sharing of information as a public interest disclosure promptly to a relevant authority, which was the wording we used at that time. Also, briefly, just to make you aware of the Herbert Protocol, this is in anticipation, and it's used in situations where a person has dementia. And as you can see here, it's a simple risk reduction tool to help police in search for these people if they go missing from their own homes or a care home. And it's a vulnerability index here. It's named after George Herbert, who was a war veteran from the Normandy landings. And again, if this happens, you call the police in 999 and let the operator know that you have a Herbert protocol. This sets out what is actually on that document there. The medication required, mobile numbers, places previously located, and importantly, a recent photograph to be able to identify them. And again, that just gives you a recommendation of that. It's throughout the UK, but this is the Police Scotland version of that. And again, it sets out there, should be aware that the information will be recorded and assessed by officers on police systems. It will only be used for that specific inquiry and can be handed back thereafter or destroyed, whichever is preferred, and any photographs will be returned. So very clearly what happens to the information that's there, and with whom it is likely to be shared as well. And the officers will seek your views on this after they've traced the person reported as missing. So that's a very quick rattle through some of the principles that are there, which I hope is helpful to you. And if there are any questions, I think we've got an opportunity for doing that later on.
Thank you very much, George. I find it really interesting when you bring it to life with some of the real life experiences of the importance of sharing that data. So thank you so much. I wonder if you wouldn't mind. So one of the questions that we've had and that we've been talking about is the benefit of having that Caldicott guardian within your locality or within your board area. I don't know if you could maybe talk to us a little bit about that. In terms of obviously as your role as UK chair, you know, what benefit do you see that brings?
I think it's got enormous benefit because you've got better understanding of the situations in which you might well need to use information rather than just a very generic high level appreciation of it. So, I mean, there'll be very particular circumstances that are there. I mean, with the, just trying to think, with the, is having ready accessibility to it as well. Quite often if you need, if it's a public interest disclosure, it's no good doing that in 10 days' time. You need to have that fairly promptly. And as I say, paraphrasing the GMC, if you're going to make a public interest disclosure, it should be to an appropriate agency and it should be promptly. And certainly if it's child protection, for example, you don't want to delay with that, because that's when you get these horrific circumstances that things go wrong. And we see these tragedies regularly replayed. So we need to learn from that. So it's important to be able to share information, but to do it in a safe way. And people get worried professionally about being criticised for that, whereas if they can speak, and we work very much as a team. So myself, Safia as the CSIRO, but probably most importantly, Alison as the DPO, the Data Protection Officer. It is a team sport, as I keep on saying here, that people can speak to us, I would hope, without any undue delay, and we can give them sensible advice. Quite often, the three of us will want to have a quick catch up if, as I say, it's something that's going to potentially have consequences for an individual with that.
Sure. Thank you, George. Now, where would colleagues get the information about who their local Caldicott Guardian is?
It should be on the intranet. Typically, I mean, it is on the source there that I'm the Caldicott Guardian, and we do try and publicise it through the information governance and security group as well. So we try and make sure that people know who the personnel are with that. Not saying we couldn't do even better with it, but that should be available. It's quite interesting in England and Wales. There's a statutory requirement to give consideration to having a Caldicott Guardian, and if you don't have one in health and social care, then you need to justify why you're not doing that. So it's slightly odd. It's not a specific statutory requirement to have one, but you've got to have consideration to that. That doesn't apply in Scotland. But the consequences of those statutory requirements coming in south of the border mean that we now have, I can tell you as of last week, 38,820 Caldicott Guardians throughout the UK. So it's probably even more significant in the other home nations than it's been with us. But all of the territorial and special health boards have Caldicott Guardians, and we have a Scottish forum where we meet up to have advice. With the UK Council, there's a website that's there, and again, you just put in UK Caldicott Council into Google, and it will come up with that. And there's a very useful manual that's there that you can look through. I don't mean just as a single document. There's various areas set up on the website, and we're technically a subcommittee of the National Data Guardian for England, which is part of the Department of Health and Social Care, but it's a UK-wide phenomenon here. And as I say, that the mantra that I mentioned earlier is it's important to use data lawfully, ethically, and appropriately.
Okay, thank you, George. And so colleagues can then Google that in terms of understanding who may be the local Caldicott Guardian for them, yeah?
Yeah.
Great. Okay. George, we will pick up the additional questions that we haven't covered and come back to you about them. And if we don't have time today, hopefully you'll be able to respond to them and we can share it with the audience if that's okay.
Yeah, sorry, and Caldicott Guardians in Scotland are on NHS Inform. So again, if you go into NHS Inform and look in there. Yeah.
Great, fab. Thank you so much, George. That's great. Thank you. It was like a seamless segue for your colleague, Alison. So Alison, can I just get you to open up your camera and your microphone and make sure that you can hear and see everyone?
Good morning. Yes, I think I can. Yeah.
Great. I'll pass over to you. Thanks, Alison.
Okay. So good morning, everybody. Thanks for having me along today to join this discussion. I'm going to give you a practical overview of what the data protection legislation requires you to consider prior to undertaking any information sharing. And this is really to give you some food for thought and some discussion points to take back to your employing organisations. And I think George has set the scene very well for how data protection and common law duty of confidentiality operate together. Next slide, please. So you've already done that, thank you. Firstly, I think it's important to start with this statement that data protection is not a barrier to justified data sharing. There's nothing in the legislation itself that prevents the sharing of data. It simply provides us with a framework to help us be confident that we can share personal data appropriately and lawfully. I think it's helpful if we view data protection as facilitating or enabling appropriate data sharing. And the key words there that George used, and I think I've repeated twice already, are that appropriate data sharing. So of course, using the framework may help us to be confident that in certain circumstances it's not appropriate to share data. Next slide, please. Effective information sharing underpins integrated working, as we all know. We often work together across organisations or boundaries to deliver services that are aiming to protect the public or minimise the risk to individuals. This partnership working typically relies on systematic or routine data sharing, where controllers, which are the organisations responsible for compliance with the data protection law, share personal data with each other or with third parties. This is planned data sharing, underpinned by the production of information sharing agreement between the controllers. There are two other main ways that data sharing may occur, or where the question as to whether data sharing is necessary may arise. And these are in response to unplanned or unexpected situations resulting in one-off ad hoc disclosures of information. So you won't necessarily have an information sharing agreement in place that would support you in these instances, but you still are required to document your decision making. Next slide, please. So all data sharing scenarios, regardless of whether they're planned or ad hoc, must consider the purpose and benefits of the proposed sharing, and these should be clearly justified and documented. So this is your starting point. In a routine and systematic scenario, it's good practice to consider conducting a data protection impact assessment to help with this thinking and for you to assess the risks of your planned activity against the data protection principles. The gateway to getting data sharing right is always to share personal data fairly and in a transparent way in order to comply with the first data protection principle. So in order to do that, you should ask yourself a number of questions regarding reasonable expectations and how well informed the individuals whose data you are planning to share or have been asked to share are about the use of their data. So is it in line with what they would reasonably expect? Do you know of any consequences of the sharing that would adversely affect the individuals? When you collected the data in the first place, did you tell the individuals that you would never ever share their data? Did you previously provide information in an easy to understand way? So George made reference to the privacy notices. GDPR emphasises fairness and transparency through the right to be informed. Privacy notices tell individuals what data organisations are processing, why they're processing it, who it is shared with, how long it's kept for, and what their rights are in relation to the data, amongst other statements. Privacy notices for routine and systematic data sharing should be available to the individuals whose data is in use, providing them with the opportunity to exercise a right under GDPR. So that might be the right to access. So what data are you holding about me and who have you shared it with? They might want to try and use their right to restrict the processing of their data, or they may wish to object to the processing of their data. Next slide, please. So looking at lawfulness, this is also part of the first data protection principle. So you should firstly consider if you have a legal power to share. So for public bodies, this will be originating from the law that's linked to your statutory duties. So within the NHS, the 1978 NHS Act provides all of the boards with their statutory duties. There are 6 lawful bases for sharing standard personal information, so name, address, date of birth, this type of personal data. And these are defined in Article 6 of GDPR. And you need to identify at least one of these lawful bases before you start to share any data or before you start to process data. In order to lawfully process special category data, you must also identify a lawful basis under Article 6 and a separate condition for processing under Article 9. So special category data, as you all well know, is sensitive and includes health information, criminal convictions, etc., amongst other types. At this point, you must also consider the common law duty of confidentiality and whether a disclosure of confidential information without consent is justified. No single lawful basis in Article 6 is better or more important than another. The list is not a hierarchy. Which basis is most appropriate to use will depend on the purpose of the processing and the relationship that you have with the individuals. If we are a public authority and we can demonstrate that the processing is to perform our functions as laid out in law, then we're able to rely on the public task basis or Article 6.1e. Private sector or third sector organisations are more likely to be relying on legitimate interests as a lawful basis. Under Article 9, public authorities across health and social care, when they're processing special category data, are typically relying on Article 9.2h, which states that the processing is necessary for the provision of that health and social care or treatment. The Article 9 conditions are extensive, so if you're not familiar with these, I recommend you take a look at Article 9 so that you can see the scope that the conditions provide controllers with when considering the processing or sharing of data. It's important, I feel, to note that GDPR does not favour the use of consent. It's simply one of the possible lawful bases. Public authorities, employers and other organisations in a position of power over individuals should avoid relying on consent unless they are confident that they can demonstrate that it is freely given. This is a fundamental aspect of GDPR. If you cannot offer a genuine choice to the individual, consent is unlikely to be appropriate. Consent provided under GDPR can be withdrawn, so when using this as a legal basis, there must be a true choice for the individual to withdraw their consent. So this is complex, as at every stage of the data processing or data sharing, you must have an appropriate lawful basis, and that may change throughout the patient or the service user's journey. Next slide, please. So just going back to the key data protection principles that we need to ensure data sharing complies with, we'll take a look at necessity and proportionality. So questions to be asking yourself in this case are, is the sharing really necessary? Could the purpose be achieved in another way without sharing the personal data? Is the sharing proportionate to achieve the purpose that you've set out? So to assess proportionality, it's essential that we talk about data minimisation, which is another of the data protection principles. For example, are you using the minimum amount of data required? So that is where we have commonality with the Caldicott principles. Can the sharing be carried out in a less intrusive way by reducing the number of data fields, for example? Is it necessary to share a full file set, or can you just take part of that in order to meet the purpose? How the sharing physically happens must meet the requirements of the security principle through the use of organisational and technical security measures applicable to the situation. So are you talking about sharing data through joined up ICT systems, or is this sharing data in a one-off transaction, which may be through email? The security controls need to match the context that the sharing is operating within. And examples could be strong passwords and encryption of data. Finally, all of these considerations and decision making must be documented to meet the requirements of the GDPR accountability principle, which requires controllers to demonstrate their compliance with data protection legislation. Documenting your deliberations helps with the balancing of the risks of sharing versus the risks of not sharing, and supports the justification for the actions taken. I probably should mention here at this point that the ICO has very clearly stated that in emergency situations, so in those ad hoc emergency situations, the key aspects for you to define are the necessity and the proportionality of the data sharing and documenting that. So they're very clearly saying there is nothing in GDPR to prevent you sharing data in those emergency situations, but you must have considered these two key principles. Next slide, please. So just to recap, we briefly touched on considerations that need to be made to decide if data sharing is appropriate and can proceed, from justifying the purpose through to documenting your thinking and rationale. And we've mentioned a number of tools, either myself or George, which would assist you to balance the risks and document your decisions, and provide individuals with awareness and transparency about the use of their data. So data protection impact assessments, data sharing agreements, privacy notices, and keeping a record of your sharing decisions. Hopefully you can go back to your workplace and seek out these key tools and ask questions about what data sharing agreements are currently in place to support you in your practice. I've suggested a few resources here as well. So the slides will be circulated and these are linked. Within Scotland, there is the Scottish Information Sharing Toolkit. This is a Scottish government-led initiative, and I'm going to say it's mandatory for all public sector organisations. I'll maybe check my fact after that, but I'm pretty sure they have ruled that out as mandatory. Certainly across health and social care, we are using this a great deal. I know some other public authorities are not using the exact same model, but we are seeing it more frequently across the piece. I would recommend, if you want to see examples of information sharing agreements, the Welsh Accord on the Sharing of Personal Information is a long established accord across public sector within Wales and private and third sector partners. And they have a register where they provide details of all of the ISPs that have met the standard of that accord, and they publish them. So this is a good resource. Just make sure you filter it for 2018 to the current date. So there are some old ISPs still within their register which were developed under the previous data protection regime. So we need to make sure we're compliant with GDPR, but the fact that the old ones are still there can actually show you the differences in the two legislation if you are interested in that. Anyway, that is well worth a look. So thank you for listening, and I'm happy to take any questions.
Thank you very much, Alison. Really interesting content and resources. So hopefully colleagues find that helpful, and they will be embedded in the slide deck. Can I just ask you, Alison, a question just about the ability for people to give their consent, and sometimes that happens verbally. So through the course of our engagement with people who were in recovery or people who were supporting those in treatment services, we heard a lot about how relational based approaches means that sometimes you can have contact with people over the phone, you know, and they're maybe in services or they're maybe in hospital or whatever. And how do you overcome that where you've got verbal consent from an individual to share their data? How do you overcome some of that?
I'm not sure I can answer that question in terms of my practical experience. The law is telling you that the consent needs to be affirmative and explicit if we're talking about sharing special category data. So the verbal aspect of that would need to be made more affirmative in some way, is in my view. I don't know whether George would have anything to add to that.
I think it depends on the circumstances of the case. I mean, again, if there's a degree of urgency and it's in their best interest and you need to release information, then that's a different scenario to perhaps something that we have encountered as part of an inspection process. So I think it's critical, Ruth, that try to make sure we have adequate privacy notices so that there are no surprises, as I mentioned earlier, as one of the Caldicott principles. So I think avoidance of getting into that situation in the first place. The other thing that occurs to me is that, I mean, when I see somebody in this environment for a forensic examination, I typically don't do the healthcare assessments nowadays. We have nursing colleagues that are far better at that and do it all the time. But if I'm doing an examination of an individual, I make it absolutely explicit to them, and I get signed consent as well from them that I'll be providing a report to the police and to the procurator fiscal. So again, it's trying, I think with the healthcare improvement in Scotland inspections, that in advance of it, if we're doing that, we make it clear that this may happen, because there will be certain situations where, as a registered healthcare professional, if you've got concerns about the care that's being delivered to a person, that even if a person objects, to protect others, you would need to pass on that information appropriately. Does that help answer your question?
Yeah, I think so. I think it's just it's often individual circumstances that, you know, anecdotally we know that some care can be very complicated and complex and lots of different providers and stuff. So I just wanted to understand a little bit more about how that's dealt with when it's verbal consent.
The other thing you have to do is whether it's verbal or written consent, and if it's not for primary care purposes, typically you would want written consent to be able to do that. But if you're doing that, keep a log of any decisions you make in regard to that, so that if you're subsequently challenged about it, you can say, well, this was my, rightly or wrongly, this is my justification at the time. So unless in some way you've been malicious about it, I've never known a healthcare professional or someone from a social work background be criticised when they've had the right intent, even if at the end of the day it's not been what the person said that they wanted or understood at that point. So keeping a record of what contemporaneously at the time you do it is really of quite vital importance in some of these situations.
Okay, thank you. Please, come on.
Sorry, could I just add, a thought has just occurred to me there. It just take us back to that, you know, the consent for the processing of the data may not be the same consent that you've asked for and obtained recently. So I think just to, you know, be mindful of that, really.
Okay, thank you both for a really interesting contribution and discussion. We're going to take a break, and when we come back, we're going to hear from Karen Melville, and she's hopefully going to bring to life a little bit of the complexity of working in the system and attempting to knit together multidisciplinary care and the kind of challenge around data and sharing of that data. So we're going to take a break now, and if I can bring you back at 11:05, if that's okay. Let's take 15 minutes, top up our cup of tea, and I'll see you back here at 11:05. Thank you very much. Welcome back, everyone. I hope you had a chance to get a wee cup of tea and didn't spend too much time scanning your emails and seeing what else you need to do this afternoon. I'm going to ask Karen, our next speaker, to come on and put on your camera and your microphone. Are you there, Karen?
I'm here, yeah. I think hopefully you can see and hear me.
Yeah, absolutely can. Okay, Karen, so I'm just going to pass over to you. And so for those of you that maybe missed the introduction, Karen is the service lead within Angus Health and Social Care Partnership, and she's going to chat to us today about the near fatal overdose pathway in Dundee. So Karen, over to you, and I'll come on just about a wee minute to go, if that's okay.
Perfect, thank you.
Thank you.
Yeah, so I have the absolute pleasure of being a service lead in Angus Health and Social Care Partnership, and I work with teams in ADARS, which is our Drug and Alcohol Recovery Service, which is a health and social care team. I also have the Homelessness Prevention and Support team and volunteering and 2 support accommodation units. And for me, it's an absolute privilege to see how they are working really closely together, helping people who are affected by drugs and alcohol. However, I'm a pharmacist by profession, and in a previous life, the Dundee near fatal overdose pathway was something that I had taken forward. So when I was first asked to do this, I thought, how do I get what was 2 years of discussion and things like that into a 20-minute presentation? So I'm going to give you a bit of a whistle-stop tour of our experience, and I'm happy to take questions at the end if that's okay. Next slide, please. So I think in Tayside we had, I'm going to take you back to about 2015, 2016, which seems like a lifetime ago now with everything that's happened. But during that time, Dundee was growing and gaining the unenviable title of being the drug death capital of Europe. We were looking at escalating drug deaths, increasing numbers of near fatal incidents. And we had a really well-established drug death review group, and we also had an overdose prevention group. But during that time, there was frustration growing amongst the teams that we needed to be doing something much more proactive. We were getting fantastic learning from the drug death reviews, but they were often quite some time after the incident had happened. And we weren't actually sure if it was reflecting what was happening in the local areas at the time. I'm just going to fast forward you on to 2017-18, and at that time again we were still seeing escalating drug deaths, and the best efforts of the services didn't seem to be able to prevent this from happening. So we were absolutely sure at this point that there was something missing from what we were doing and our assertive outreach. Around about the same time, Dundee ADP commissioned a drug commission to come in and have a look at services across the area and what was happening, and was there anything else that we could do. And this was an independent review. The result of the report was that a more assertive outreach response was possibly required, and that was something that we should absolutely be taking forward. The big question was, how could we do this? So in 2018, we had the unfortunate circumstance where we saw a cluster of deaths and also a cluster of near fatal overdoses all happen in one area of Dundee in particular. Through our public health colleagues, we set up a problem assessment group, and we looked into what was happening, and we quickly discovered that there was a new substance circulating in that area. It was a new benzodiazepine that we had no experience of in Tayside. However, a bit of quick research showed that our colleagues in Glasgow had had experience with this benzodiazepine. It was much more potent. The people in Dundee weren't aware. They were still trying to take the same amount of benzodiazepine that they'd taken before, despite the fact that the potency was 10 times that of what they'd been used to. So we were able to put quite a quick response out to that, but it still left us feeling we're not being proactive enough around what's happening. So through the overdose prevention group, we set up a near fatal overdose response with the harm reduction team in NHS Tayside. They were able to get an information sharing protocol in place between the Scottish Ambulance Service and themselves as an NHS team to share information around individuals who had experienced a near fatal overdose and had been transported to hospital. This worked well, but it was very person dependent. All of the information was shared between one individual within the harm reduction team. What we did notice really quickly, though, was the information sharing protocol only allowed that harm reduction member of staff to share that information with NHS colleagues. So if the person had experienced a near fatal overdose, they couldn't and weren't open to substance use services, that information wasn't shared, which left a gap. So we needed to do something very different about this. As you can imagine, sharing information, people were really nervous about it for all the reasons that you've heard in the previous presentations. So what we did was we looked at the cluster of near fatals that we'd had in that area with the benzodiazepines. We sought Caldicott permission for a multi-professional group to come forward and do a deep dive into those individuals to review the circumstances of what happened leading up to that near fatal event and then what happened afterwards. It was a multi-professional group, so we had police on that group, because we did notice through our overdose prevention group that the police often were aware of these near fatal events before SAS were, because they were called to those events as well. But they weren't sharing that information in particular, except perhaps through adult concern reports, which didn't always come back into services or elicit any a response in a timely manner. We were really lucky to be able to work alongside our adult protection colleagues in both health and social care and in the council area in Dundee to get that high-level Caldicott approval to do that deeper drive. We set ourselves 6 weeks to look at those individuals that had been affected and to look at what the circumstances were, as I said before, around that individual, what treatment services were they open to, were they open to third sector agencies? And we came up with 2 cohorts of individuals that were affected, and it was almost a 50-50 split. So we had 50% of those individuals who were open to substance use services and in active treatment and receiving opiate substitution therapy, and almost 50% of individuals weren't open to traditional NHS services, but were open to adult social work services, third sector agencies. We also examined our current near fatal overdose response, and we noticed that it could be up to 28 days or more before there was actual contact with the individual. Now, all the research had shown us that you need to be able to get a quick intervention, brief intervention in when someone experiences a near fatal overdose. A month or so later, they'd kind of forgotten about what had happened and they'd put it to the back of their mind. So with all of this information, we then set about how could we change what we were doing. And we sat down with our information governance colleagues again, our Caldicott guardians and our services, and looked at what we could practically do. The police took the reins around getting an information sharing protocol, because that would allow us to share information from all police services at that time within Tayside. It has since been updated with the move to Police Scotland. And we got consent from the information governance officers within the council areas, our third sector areas, to share information and start a test to change, which would last for 6 weeks around reviewing near fatal overdoses. What we wanted was people from multi-sector agencies to tell us about near fatals. Now, you can imagine that what happened was most of the information came in from the Scottish Ambulance Service, and that's thoroughly what we expected to happen. But actually what we found was around 50% of the information came in from the Scottish Ambulance Service, and an additional 50% of information came in from the Scottish Police Service, which was absolutely fantastic. We needed, before we started the 6-week test to change, we needed to increase the confidence of the team that were going to be around that table reviewing these incidents, around appropriately and confidently sharing information on these individuals that we were going to be looking at. So we did desktop exercises with information governance at the table. We took some case scenarios, and all of that was about building the confidence. And as we started the test of change, people became more and more confident in what was happening. So in November 2019, so as I said, this is a very whistle-stop tour of what we did and try and get through this quickly, we started a 6-week test of change. Next test slide, please. I'm pleased to say that that 6-week test of change is still in place today. It's changed and it's updated as things have moved through, but its concept is exactly the same. Before we had Microsoft Teams, we actually set it up as a daily teleconference. That wasn't easy for me to say, I apologise for that, where we had the Drug and Alcohol Recovery Service, that was health and social work, on the call, Police Scotland, our public health colleagues, criminal justice social work, the specialist harm reduction team, and 3 third sector agencies. We also had within the information sharing protocol that we could share information with the prison service, because one of the things that we'd found from our deep dive was that some individuals had unfortunately been arrested on the back of their near fatal event, ended up in custody in a prison service somewhere, but the information about their overdose hadn't been passed on. And we felt that that was really appropriate and should have been passed on to help reduce the risk around those first few days in prison. So we started off quite slowly, taking the information, reviewing. We made a decision that we would have one chair. We would also decide the appropriateness of which calls were going to come to the meeting to make sure that they met with our information sharing protocols. And as I say, slowly people became really confident in using the system and bringing people for review. We would screen individuals out because we felt that it wasn't appropriate within our information sharing protocol, but we were always very aware that if there was a risk to the individual, that we would seek to pass on that information from a risk point of view to the agency that they may be open to. So I guess that's where we got to, and as things progressed, it moved on to a Teams call daily on encrypted channels within the NHS, and it was only those that were invited that could come onto the call. As I say, the information sharing protocols have been tweaked and changed as we've gone through, and it's still successful today. It was then rolled out to Perth and Angus, and I think we also received a COSLA award for this as a best team around reducing risk for individuals. We also sought feedback from those individuals who we'd reached out and made contact with, and they were really happy that we had shared that information and actually taken the time to go out and meet with them. And because it was an assertive outreach approach, often the teams were meeting family members who'd been affected and were able to offer advice and information to them as well around providing harm reduction information, supplying the lock zone, working with them, and that real sort of whole family, whole system approach. So I'm just going to share with you some data about our first 2 years of the group on the next slide, please. Because I think it's really important, and this is what gave us our drive and premise to move forward. So the first 2 years, the group actually looked at 1,048 incidents. Now those related to only 538 people, and actually 197 of them were repeat incidents. And of those 197 people, those repeat incidents were accounting for 707 incidents over those 2 years. But you can see from the graph on your right that over the 2 years, the number of near fatal incidents started to fall, and that's really continued. We've had blips around, but when we saw big blips, we went back and had a look to see if there was any consistency around those. Was it a new drug that was circulating? What police intelligence was available within the areas? I think a lot of we were able also to dispel some myths, because lots of people said, oh, overdoses happen at the weekends and on public holidays. But you can see from the graph on your left that that wasn't necessarily true. We had a pretty even spread across the week, with some definite increases on a Wednesday, a Friday and a Saturday. Wednesday turned out to be payday. That's when a lot of people got their benefits. So that was part of the risk reduction as well, is to try and help people manage their money better over the week. And actually what we tried to do was get to people within 72 hours of the incident being reported. And I'm pleased to say that in the first couple of weeks of that, over 70% of the people that came forward for screening through that group, we saw within 72 hours, and some of them the same day or the day after. The reason that we set 72 hours was because largely the services are Monday to Friday services, and that is something that I think we do need to look at going forward. So I guess that is my quick whistle-stop tour of where we got to. I have to say the feedback at the end of the 6 weeks test of change was that nobody wanted to stop this, and we made sure that we got the information sharing protocols up to date and all the agreements with information governance, our Caldicott guardians, adult support protection, to continue to share this information moving forward, because services saw the benefit of it, but most importantly, the people who were affected by this saw the benefit. And it's also helped with our planning moving forward. We're much faster to recognise changes in substance use across the area. and to put in appropriate harm reduction measures. Sorry, that was very quick, but it was the culmination of 2 years' work, and it's still going on. Thank you.
Thank you very much, Karen. And it's actually really a fantastic example of where you're able to intervene at pace, because I think that's certainly what I'm taking from what you're saying, that actually doing it within that 72 hours is critical, because it's quite fresh and it's still a kind of active issue for people. I wondered if you would tell us a little bit more about any feedback you've got or engagement you've had with some of the family members. We speak a lot to family members who are attempting to support their loved ones or are supporting them through either the kind of active addiction or recovery. I just wondered if you could give us a wee bit of insight into your engagement with families and what their feedback has been, perhaps.
So again, as I say, that you through the sort of assertive outreach approach, because you're going out to where the person resides, you'll often come into contact with family members. And I think it can be a blessing or a problem as well. You know, if someone who's affected by substance use has been almost concealing what they've been doing to the family member, that can be difficult. But you know, this is about saying that people are there to support them. We need to know exactly what's going on in order to be able to put in the correct treatment measures and to work better as a family. So I can think of one example through the near fatal overdose group where the family really just wanted to help, but what they wanted to help to do was just to stop the person from using substances. So they didn't want to work together, you know, as in family sessions, but what we put in was work with the family members to help them understand substances and their effects, how it works, harm reduction methodology and things like that. So they were much more aware then that for some people, it's not about just stopping using, it's a process. Teaching them about changes between lapses and relapse and how to help support people. Thinking about blame as well and more understanding. That had a fantastic outcome, and the person themselves felt that they could be more open and honest with their family too, and the services around them.
Yeah, it is a really difficult one to get right, isn't it? Because I take your point, you know, sometimes situations are very private and people don't want their family knowing the extent of the situation that they're finding themselves in, but we know that families are keen to provide that support. So I absolutely get it's unique and every situation is entirely different. See, very quickly, Karen, one of the questions I'm keen to understand a little bit more about is you have multidisciplinary approach, let's say. How did you overcome some of that data sharing concern? Was that a discussion point as a group? Like, how did you overcome some of that? I don't know if you could share that with the audience.
It was absolutely a discussion point and it was very key. And I think what we'd found a lot of the times was people were saying, oh, I can't share that information because of GDPR. And I hope the presentations earlier showed people that, you know, we do actually have a duty to share information if there is a risk. And so we spent a lot of time educating staff around what GDPR was, what information governance was, getting input from the adult support and protection team about appropriate use of data sharing and passing on information to reduce risk. And I think having the information sharing protocols in place for people really helped too. But most importantly, being able to work through the concept as a desktop exercise, doing information governance to be there and say, well, you know, that is appropriate to share that information and you should be doing that because the outcome is that you'll be able to reduce risk. So people became more confident with it moving forward. And I think it's appropriate sharing of information. We've heard that a lot today. You know, if you've got health members of staff or social care members of staff, you're not wanting entire histories shared. It's more what's pertinent to what we're seeing for this person at this time. And I think what we really tried to take was a person-centered approach to it to gain a better understanding. We also really emphasised that, you know, this wasn't about sending just anyone from the team to do the assertive outreach. If someone was already open to a team and known, it was that team that did the assertive outreach because the person was known to them and that trust was there. We reviewed all our consent statements as well within the services. And and looked at that. So to make sure that we were telling people at the outset of coming into services that we would be sharing information.
Yeah.
SAS obviously have that high level information sharing protocol now, but they will override that on certain occasions too, if people say, no, I don't want you to share my information, if they think the risk is really high too.
Okay.
So yeah, it was a huge learning process for everyone.
Mm-hmm.
But I think at the end of the day, what we had was people who were interested and wanted to do something better, more pertinent, to try and help people who were at risk.
Yeah, it sounds very personalised as well, Karen, from how you describe it.
Absolutely, every approach was different.
Yeah. Are you happy for colleagues to reach out to you, Karen, and just maybe pick your brain or discuss this in a little bit more detail based on their own local situation?
Yeah, absolutely.
Great.
More than happy for that.
That's fantastic. Thank you, Karen, so much for sharing that example, and I'd really welcome actually any outputs you've got from that or any evaluation of impact, because we could certainly share it across colleagues that are attempting to think about MAT standards 3 and 8 particularly, and some of that joint working stuff. So if you've got anything, that would be fab. Can I just, we're going to bring things to a close. These webinars always go really fast. We do have a poll coming up, so please take the time as I finish off and wind us up to kind of complete that poll in order for us to get a better understanding of the content that we've shared today and the value that it adds to you. Can I just take the opportunity to thank all of our speakers? Whilst you see about 15 minutes of their presentation, we realise that a number of hours and time and meetings go in the background to make sure that it feels seamless to the audience. Can I just thank the team behind the scenes who facilitate all of that? And we have a huge team of colleagues who are participating and making sure it feels as seamless as possible to you guys. And before we go, can I just ask you all to keep an eye out for future webinar subjects. So we have got one that we're planning to do before the end of March, and based on the feedback that we get, we will design what that looks like based on the needs of the audience. We will issue out to you an event summary as well, just to give you some of the questions that we didn't get a chance to cover with the speakers and get the responses to them and send them out to you. So thank you very much for all of your participation and time. If for any reason anybody wants to follow up with myself or any of the team, please do let me know about that, and I will see you in March for our webinar on MAT. So thank you very much, everybody. Have a great day. Thank you.